Welcome to the Health Tech Edge, the podcast on how technology is reshaping healthcare operations. I'm Mike Moore. Each episode is a practical conversation with leaders who are building, buying, or running tools that reduce administrative burden and improve productivity in healthcare. Today, I'm joined by Dr. Fara Kamangar. Fara is a board-certified dermatologist in California with an engineering background, and she's the founder of DermGPT, a tool built to help dermatologists and care teams move faster through high-friction work like inbox triage, documentation, and prior authorization support. In this conversation, we're going to hit two connected themes. First, how you fix the inbox and cut pajama time without adding more humans and more handoffs. And second, why trust is the real product in clinical AI. If a tool gives one weird answer, it can lose the room. So we'll get into how she built DermGPT to be precise, curated, and willing to say, I don't know. Fara, welcome to the show.
Thank you so much for having me here.
All right. So, day in the life of a dermatologist, right? You're working with patients all day, but we know there's a lot of documentation that's needed as well, just to put in your clinical notes. And also, I have to imagine a fair amount of research, right? Just trying to figure out what's going on with patients. So talk to us a little bit about kind of day in the life of a dermatologist before DermGPT and kind of how you work.
Absolutely. So dermatology is one of those fields where there aren't that many of us. The field is less than 2% of the House of Medicine. And then we have a lot of patients because basically the whole population has lots of skin conditions, lots of referrals. What ends up happening is 3 to 6 month waits. Some of our appointments are 10 to 15 minutes. So some dermatologists could see upwards of 30 plus, sometimes 40 patients a day. And that's, a little bit variable, but that's not an uncommon situation. And so when you have that level of patients, because in primary care in comparison, it could be sometimes even less than 20 patients a day, for example, or less than 15. So all the problems, if you have a little bit of errors or a little bit extra clicking, they're just multiplied. You have a lot more patients, a lot more charts to go through, a lot more patients messaging you. It's just problems of volume. So if you're doing something a little bit inefficiently, the more times you're doing it, the docs can get a little bit burnt out. I mean, we really saw this. Dermatologists used to be pretty happy, like on burnout scores. Even before like 2012, we were always just like notoriously like, well, the derms are very happy people. And then you saw the burnout scores start to go up as soon as like the electronic health records and things kind of hit the market. Because if you create a little bit extra friction and then you multiply that, times the multiplier, then it can lead to basically burnout. And then what we see is in ambulatory care settings like us, for about 8 hours of patient-facing time, you get about 5 hours of electronic health records admin time. For subspecialty, that's, there's not a whole lot of us, so you don't want to be wasting a lot of time not seeing patients. But that's usually the common challenges that tech kind of brought in. But then now I think post AI, we can hopefully alleviate some of that.
Well, and that overflow work of the 5 hours, like where does it go? Of course, it doesn't happen during the day when patients are coming into the office and the support staff's available and all the good stuff there, right? It flows into your evenings, and that's this expression pajama time that I think many in the industry are familiar with. So talk to us a little bit about the impact on pajama time and kind of how you think about that.
Yes, 100%. I mean, pajama time sounds like a good thing innately. It sounds like a very relaxing time, but in the medical sense, it's kind of anything but, because exactly like you mentioned, those hours don't just magically appear. You don't have time to do it in clinic. So we see often clinicians, it's technically in many centers, 6 p.m. and beyond is technically that pajama time, like when you really shouldn't be in clinic necessarily. But then it's not uncommon. We sometimes see doctors on their electronic health records at like 9 p.m., 10 p.m., 11 p.m. for hours. They're answering messages. They're completing their documentation. I mean, this is like, and a lot of times I'll say for the mom group, they'll say, well, I get home, spend time with the kids, do dinner. And then after the kids are in bed, then they get on to, then that's when you're seeing a lot of those, like that demographic of the 10 p.m., 11 p.m. And that's just, maybe you could do that once or twice. But if you do that every night that you have clinic for a 20, 30-year career, you can imagine that this is a lot where the burnout and friction kind of starts to begin.
Yeah. And there's obviously intense pressure on dermatologists. You know the industry certainly better than I would, but I know for my dermatologist that I see, he used to be in a practice which was, primary and, every specialty, everything kind of under one roof. Now he's in a dermatology only practice, but there's got to be pressure just from a profitability standpoint, right? Like you would say like, well, see less patients, right? But the reality is there's financial pressure to run a successful and profitable practice, and no matter what setting you're in, I'm sure. And that's where that 30 to 40 patients a day comes into it, right?
Exactly. That's such a good point that we actually can't ignore, because along the time that all these like health record things came in and the work went up, reimbursement rates went down comparatively. So, I mean, the two things kind of collided, really, I would say. So you're having to now, like you said, just to keep the lights on, you have to see more patients too. And seeing more patients equals exponentially more work. We've done some trials where we've seen, like, for one physician that does double the work of another physician in terms of patients, like double the patients, their inbox messages and kind of outside work is times 5. So it's not times
Wow.
2. It's not like you see double the patients and it's times 2. It's like this exponential increase. So all of that kind of just creates this situation of not enough hours in the day.
So what led you to the moment where you decided something has to be done, and, the path that led you to founding DermGPT?
Yeah, I've done a lot of health tech consulting, of course, for over the years, and background in engineering. Anytime I saw anything in clinic or in the hospital, I always, my brain goes, what technology could fix this? A lot of that kind of 2013 to 2016 era of electronic health records, it was, well, actually, how could this technology be made better? So those were the eras. And then as soon as generative AI hit, like the first time I got my hands on one of the ChatGPT APIs, I think for me that was like, this is the moment. Medicine will not be the same after this. All these problems I've been thinking about that are language-based and textuals, we now have a solution. I think it was literally, I was one of the first 1,000 or so to get access to the ChatGPT APIs, and we started just building DermGPT on that like right away. It was just like, medicine will not be the same, and it won't. I mean, the future is now completely different. All the docs now, whether institutions are allowing them to use AI or not, the data shows the majority of docs are using AI. I teach to some of our medical students, and they're all on AIs. And I'm like, they're the first generation that's being trained with AI. So they're completely different than how we are. They're almost like cyborg trained, half AI, half medically trained medical students that are going to come up. So that's basically for me. I mean, I think that was it. I was like, all these problems we've had, we can now fix it. We're going to introduce new problems too, because AI is not perfect. I think that's the most important thing people need to realize is what it can do and what it cannot do. And I think at this point, there's a lot it cannot do, even though the headlines always, kind of point to it being perfect and saving the world and all of that. But there's still a lot of guardrails that we need to have. But for me, I think that's been the most transformative tech we've had throughout our whole health tech, generation, past like 10 or 20 years. So
Yeah, and it does represent a huge opportunity if you're optimistic and look at it from a positive point of view, but it's also, there is risk, as you point out, which we'll get into a bit more here in the conversation. But I think having that light bulb moment for you go off and kind of say like, wow, there's a great opportunity here. I mean, I know the first couple of prompts that I ran through ChatGPT when I first learned about it, and it was with my son who was in high school at the time, and, helping him, like I said, like, what are you reading in English class right now? And then, pop up a quick essay on whatever. Like, to me, it was like the light bulb moment around that. Obviously, you looking at it from a dermatologist lens, you see the opportunity, and I'm sure that people are. I know, I've told the story on the podcast in the past, caring for a family member through a medical crisis that they were going through, and taking every conversation, every note, every test result, and just building a monster thread in ChatGPT to just help me understand what was going on and what questions to ask. I have to imagine that there's a fair amount of that coming into the clinic each day too, where maybe as you're delivering results from a test or a biopsy, or just explaining potential things, that your patients are likely using these tools and coming in and changing the nature of the conversation with you as well, right?
absolutely. I mean, there used to be the traditional, your patient was going to Google something and come in with that kind of semantic search on like a Google word based, but that has its limitations. But now that they have this just complete, the access to like a chat GPT where they can have conversations back and forth and come up with like all this data when they see you, is fantastic. And then on the flip side of it, as you can imagine, because we have so many visits and they're shortened, our communication to patients has really suffered. And if we don't have time to communicate, that only, leads to maybe worse outcomes and treatment, non-compliance. So that's not good. But it also actually leads to more messages from our patients, which then kind of feeds into the same loop of the hours kind of being taken up. So one really popular use case actually on DermGPT has been the patient handouts and patient FAQs. So we've kind of told all of our colleagues now that are using it. We have over 4,000 derms using DermGPT now, just because it's kind of been easy for them to take up. It's similar workflows that they've seen. But I usually just tell them, make sure everybody gets an FAQ page. Businesses do this all the time. Usually this is literally one way to try to cut down volume, but we don't really necessarily do it in medicine. But like literally an FAQ page for this is the condition, this is the medicine I'm going to give you, just like write up the top, 10 most pertinent things this patient should know, when to expect this medication to work, when to expect, this to hit. Because sometimes it's a little bit delayed. Like let's say for acne, for example, we might want you to use something for like 4 to 6 weeks. And then it's not uncommon the second week someone messages you, nothing's happening, that kind of thing. So it's like a simple explanation, but of course it can get more complex than that. But that is like a no-brainer. It can be generated in like less than 30 seconds, basically, especially we have agents with a prompt kind of pre-populated. That alone could cut down a ton of, incoming messages, but more importantly, just gives more info to your patient so they don't have to go home and ask questions and maybe get wrong info because you've done that pre-work for them and reviewed it just to make sure it's accurate.
Well, I think we've all received handouts from the doctor, right? That, kind of you
Yeah.
went in. I mean, even I went for my annual physical a few weeks ago and they gave me both the flu shot and the pneumonia vaccine, at the same time in the same
Yeah.
shoulder, two different handouts. I didn't read either of them. Then I
Right.
ended up having a reaction to it and wish that I'd kind of, but it's the ability also, like if you are talking about there's a diagnosis of some kind, right? Or potential, it could be one of these two. We're going to do a test or a biopsy or something. We're going to do whatever. And then there's a medication. And then you're giving a couple of different handouts. Sounds like you can put together that information in one cohesive patient
Yes. Yep.
FAQ or take home kind of that somewhat synthesizes that information, right? To kind of make it, think like the brain thinks, right? Like, here's what I'm dealing with. Here's the treatment the doctor's recommended. What do I expect? What are reasons that I should call the office? Those kind of things that maybe synthesize the information in a way that it makes it a
Absolutely.
little bit more human and readable.
I think you explained it perfectly. It's like we all leave the doctor's office with all those handouts. Who actually reads them? To some extent, and then they're generic. They're not tailored to you or what you just had done. Whereas with generative AI, you can make it down to one of our like more popular ones was like a use case I had with having a patient tell me that he loves the Minions. He was like an 8-year-old, and we're like, okay, we'll make it Minion speak in an 8-year-old's language. And like the kiddo loved that handout and like read it and actually followed the directions. And his
It's
eczema got a
amazing.
lot better. But you can now I tell all our pediatric or all of our colleagues in pediatrics or pediatric derm, ask the kiddo what their favorite character is. Super easy to like do that right away, and you get their engagement right away. You can change literacy level. You can change languages. I mean, you can really tailor. It comes down to our creativity at this point and patient engagement. So I think the tools are just available. They're there less than 20, 30 seconds. And you can really make a big difference. And because if that was really tailored to you, you might have read it and read that, maybe go home and do this or take it easy so that you don't have this robust, inflammatory reaction and you're not exhausted for the next 2 days or the actual things that can actually like help the patients.
Yeah, that's amazing. Yeah, I think we've all been to the doctor, and no offense to you and your colleagues, but we all have that. There is my wife is a registered nurse, so there's a certain amount of medical speak that I've become accustomed to over the years, but in a subspecialty, even more jargon, right, and
Yeah.
terminology that makes perfect sense to you and your colleagues in the clinic because that's how you talk and that's what it said in med school and in practice and right in the textbook. But then there is the reality of put it into English, as we would say, plain speak, for a layperson. But I think what's amazing about what you just said too is that I'm sure, see patients who come from a variety of backgrounds and cultures and education levels and languages, and the ability to personalize it, whether it's in Minion speak or in Portuguese or Spanish or whatever the language might happen to be. That's got to be a huge win because I have to imagine that that just wasn't happening previously, right? There just wasn't time. You
That's right.
handouts in English, maybe depending on the community you serve, you have English and Spanish handouts pre-prepared for things, but not for
Right.
everything that's going to walk through the clinic door.
Yeah, but it'd be like totally limited. There's many, many use cases for like the large language models and clinic space, but that's like a no-brainer one. I think everyone should just take like 20, 30 seconds, generate that. It'll be better for the patient and saves you a ton of time too. And inbox messages coming in.
That's amazing. So the one question I think a lot of folks, especially in the subspecialty space, would say is like, ChatGPT, Gemini, whatever the model of choice, Claude, a lot of the large language models, they have a lot of this information. So why do we need something specific for, in your case, dermatology,
Yeah.
but, really kind of any kind of medical specialty? could likely be served by a specific model. But what are the issues with using some of the commercial models that are out there in the market that people could just go self-serve on? People
I think
being
that's a
even
yeah,
clinicians, right? Not just
right.
talking about the public, but clinicians. What are the problems that you've seen in the self-service with those models?
100%. I think that's a great question. And really in reality, the foundational models are fantastic, like ChatGPT, Claude, and I'm on them all the time too. So I always tell all of my colleagues, use whichever model you like and you like the language. That will also probably work pretty well. Like if you just go on Claude and you use that same method, create me an FAQ, it'll probably do a pretty good job. What we have that's a little bit more nuanced that I think for the more advanced questions, it just does a better job. Sometimes the foundational models give you a little bit of a generic answer. For us, we're tapped into 60,000 dermatology articles that are vetted by us. So you're not going to get a random article that might not be applicable. You also have our workflows in there, and you have all of guardrails. So we have multiple agent phases that are saying, well, if this happens, do this. Like for example, one of them is like our DermGPT Guardian, where we really try to look for wording that might get you in trouble legally, whether
Mm,
that's in your chart note or in your diagnosis, or it might say, okay, hey, you've thought about, diagnosis 1, 2, and 3, but make sure you don't miss number 6 because that would be bad. Every once in a while, somebody might have that. It's built more for our world. And I think that the truth of it is that nobody really needs to make, I don't think, new models anymore because the foundational models are great. We even actually leverage GPT as a foundational model. But the layer we add on top of it, we're a traditional RAG model, but the layer we add on top of it is just the expert workflow of a dermatologist. So it makes it better. We have our guardrails set a bit differently because we don't want to have a whole lot of errors or hallucinations. Like we'd almost rather not give you an answer or, not be so customer friendly, but give you more, high yield information. Versus some of the foundational models are kind of set to be nice and say things you like and kind of agree with you. And so that can lead down to trouble if you're really looking for factual information and don't want to bias a physician. Because like, let's say a physician asks a specific prompt and they kind of have a little bit of opinion in that prompt, the foundational model is probably going to agree with you. But that's what it's meant to do. They're meant to behaviorally want to engage customers and kind of keep you more. And people just like to be agreed with, right? Like that's
right.
that's what these models know. So that's something I would say maybe if you're using some other model, don't put a lot of info in there. You just want to maybe put like the basic patient information, but don't tell it what you think you're thinking currently, because it'll probably just take that and just keep giving you more of, what it thinks you're thinking and give you more of that. So, but that's not what we want. We want the tool to actually pick up things you're missing. We want that, Derm Guardian to say, okay, I hear you. You're thinking you're going down this route. That's great, but make sure you don't miss this and this and this, because this percentage of, people might have gotten sued if they missed that, or this could happen if you missed that. So a little bit of a different framing, but I think they're all great tools is I think the main thing. I think everyone should leverage generative AI.
Yeah, it's making me think though as you're speaking. I joke with my family because I went back to the show ER that started however many years ago,
Yeah.
25 years ago, and I rewatched it from the beginning. It's over
Oh,
300
that's
episodes.
great. That's a lot of
And
episodes.
but it makes me think too, like what we're able to do, and I've talked about this concept on the podcast previously when we were talking about women's health with a founder who had created a company called Conceivable. Kirsten Karchmer had built this, so it's basically a 24/7 coach for women's health. That
That's
people
great.
can have for his app. This is like I think about the ER. This is where I'm thinking. This popped into my head. You had Dr. Peter Benton, the surgical resident, who has John Carter show up as the new med student, and he has no patience for him about anything. Now all of a sudden
Yes.
you have a GPT specifically programmed for your subspecialty that has not only the patience, but to your last point there, it's probably friendly enough, but it has that level of professional
Yeah.
challenge and kind of expertise and oversight to make sure that you're checking your work and to give you that perspective that you might be missing if you're going fast or if you hadn't considered something else in the potential diagnosis or whatever it might be. So I think the power of AI, whether it's patient facing, and we've talked about some of those scenarios on the podcast as well, where it can coach through taking blood pressure readings and recording that data over the phone or answering questions. It's the ability to not have the same limitations that humans have, which are time and patience in a lot of cases, right? That that
Yeah.
the AI can play a role that many humans would love to be able to have the time and luxury to be able to do, but just don't. And so building that into your tool so that it can serve the people that it needs to serve, but do it in a way that, gives them what they need versus kind of rushing out the door because, you've got another patient waiting, like, if you were trying to ask a colleague in the hallway or something.
Right, right. No, I love that's the best analogy because it's true. That's not how our medical training was. Our attendings didn't just agree with us. They would, and and kind of depends on if you train in the West Coast or the East Coast. West Coast is a little nicer, a little bit more like cuddly. So they were a little nicer, but still, you had surgeons in the OR, like the vascular surgeons throwing scalpels and things if the med student did something wrong. The GPT doesn't need to go that far as far as
Right.
aggression, but it can't be totally just going with what you're saying if there's information that, is contradictory. So I love that analogy, actually. I love the
Yeah.
analogy of the serious attending from ER.
Yeah, yeah. Well, that's the scenario that I think everyone needs. That even just in my day-to-day work here, I use ChatGPT as a coworker, right? But it's an expert coworker who has knowledge of a lot of subjects. I still need to bring my game and know what I'm asking for help
Right.
with, right? And I think that's kind of the role. But having a specialized model that you've built just for dermatology in this case makes a lot of sense. You talked a little bit about the adoption, but let's drill in a little bit more to it. So, kind of in the US, how many dermatologists do we have around?
We have about 12,000 dermatologists. It's interesting. We launched in, I think, 2023, and it was interesting to see we had about maybe 2,000 or so within a few months, which doesn't sound like, when you see these large models and they're talking about millions of people adopting in the first 5 days, but for small subspecialty, those numbers are significant. And I think what it proves is that doctors do want specialized tools. Because we've had, let's say, like even something like an UpToDate, which is a very normal reference tool that doctors have always had. Even those tools are not super helpful for the subspecialist because they're more general. They're more for primary care focus. So when you come down to the subspecialty space, you need your tool to not give you a generic answer or you're just not going to use it because you probably have that generic answer already in your head. Kind of what you need is that kind of a little more complex. So we had really great uptake. We're now a little over 4,000 derms. But I would say out of that, maybe about half of them are the super users. And we say, it seems like they're really getting into clinic, opening up the laptop and using it with their workflow every day. And then we have others that just for fun, every once in a while will prompt this and that. So I think overall, what probably will move the needle for a lot of docs for their clinical workflow is to really start adopting AI in like an everyday kind of thing. Of course, not accepting every answer it gives you. You still really need to keep that clinical acumen for whichever, foundational model or whichever AI model you use. But you will just save so much time. And I think for the super users, you really see their behavior and they've commented to us that they almost like can't live without it now. I
Sure.
joked once, one time we were doing a system update and it went down for a couple of hours. They reached out to us. They're like, where is it? We're in clinic and need to use it, which is, I think, the best thing than knowing that, your product is actually being used in a really meaningful way. But yeah, so I think there is something about having subspecialty LLMs more than just general ones.
And from a business model standpoint, is there a fee for use of this by dermatologists, or how do the
Yeah,
economics work?
right. We kept it free for board certified dermatologists. I think that was important for us to do because we want no barriers to adoption. We know technology is not the most favorite thing for many docs. And it kind of follows the same adoption curve as any other technology. You have your early adopters, then you have your really super gung-ho people, and then you really have everyone else. So we wanted kind of no barrier. We've had a lot of great educational partners who've helped kind of sponsor some of the CME and educational content that goes into it so we can keep it stable. But, we are a team around research and how to do this correctly. There are a lot of AI models out there that are really doing the business aspect of this, right? They're raising a whole lot of money and putting out a lot of marketing. But the interesting thing is when we look at our benchmarks, many times we actually, with our small team, do better in dermatology questions versus, some of the larger models. And I think that's the incredible thing. Even though some teams have a lot more kind of fuel around it with marketing and such, the foundational models are so good now that you can have a small amount of physicians because you have the expert knowledge build something on top of foundational models that's truly different and useful and reach these really, really high benchmarks. So I think it's been a really cool case study for that is that on top of AI, I mean, of course, you can create your own foundational models, have a whole engineering team, but you also don't really need to do that anymore because the foundational models are so good. with large language models. So if you're taking a group of physicians that have that expert just knowledge of workflows and knowledge and creatively making something on top of it, it's going to be a lot more meaningful.
Well, and it gives you the opportunity to apply your expertise where it's really needed, which is the curated content that's going
Yeah.
in through the RAG layer on top, right? That,
Right.
like you say, if you've got limited time in the day, which we've already established you do because you're
Yeah.
still practicing, right? Sometimes we talk to physician founders who they're not at the bedside or, in the clinic anymore. They're 100% dedicated to the tech life. If you're doing this and kind of balancing both as you are, it's really
Yeah.
important that you spend your
And that's
time on the things where you're most needed.
exactly. And that's such a good point. I actually think for physicians who develop in this space, it is important to still be in clinic because really you're building a clinical tool. So not having that connection actually just kind of takes that away a little bit. And then I'm
Yeah.
actually happy you brought up the RAG model as well. I think, what we learned, a lot of the medical LLMs just connected to sources like PubMed and other, articles. What we learned actually is if we put every dermatology article ever created into a model, the answers were actually not good.
Mm.
So we really had to dig deep and curate what goes in and really have it tiered correctly and teed up correctly and categorized correctly. It's not just, you can't just take a foundational model, stick a bunch of articles on top, and that won't yield a result. I mean, you really need to go through it like how we've been trained and how we would train another like resident, for example. So there is that little bit of that expertise that goes into how you put the data in there.
Yeah,
And you get
that's
that
I think
feedback
it's
in actual clinic.
yeah, anyone can write anything on the internet, right? So that's the risk, is that it's going to pick up something that maybe it's a study that was published, but then a year later, new data came out that showed that study was, wrong or obsolete or something, right? Like there is that kind of
Exactly.
that. So the curated nature of what you're doing, I think, makes a ton of sense. So now comes the big question, I think, for dermatology. We've talked a lot about text. Do you have images on the roadmap? I'm sure that your dermatology colleagues across the country are looking for something where they can take a picture and upload it and get some type of information. Obviously, it's never a substitute
Yeah.
for doing the biopsy or other kind of testing, especially detecting skin cancer and melanomas, all these kind of things. But what about imagery and kind of what your plans are there?
Yeah. And I think, image based is a whole other, it's like a game of kings. It's a whole other world when it comes to AI. Of course, it's something we've looked at as well. And a lot of companies are working around this. It'll be really meaningful because if you're able to have image based, let's say triage, let's say in an ER emergency room or primary care doctor, having something in front of them and seeing, is this serious or is this something that can wait? That tool would be highly valuable because it's hard to find one of us. A lot of our friends that, have us in their network or ER docs, primary care docs are texting us photos all the time. So this use case would be perfect. Diagnosing melanoma is one of the hardest things we even do in clinic. So I think that's a harder task. But again, if someone can just hop into, let's say, a machine down the street from them and it picks up something that they wouldn't have caught, that's highly valuable. But again, it's hard. I mean, sometimes we biopsy a lot too. We talk about the sensitivity of specificity of these diagnostic tools, from like how many moles you have to check to get a melanoma. And it's hard to do. And even for a regular dermatologist, like even if I look at my own sensitivity and specificity, I probably still biopsy a lot of moles before I get to a positive melanomas. Hard tasks to do, but very worth doing. For us, I think workflow, it makes just so much more sense. That's why we spend 99% of our effort there, because what we want to do is we have all these dermatologists. We want to give them back that 5 hours of admin time to do more skin checks and find more melanomas and cut out the
Sure.
melanomas. I think that's the first high yield thing we can do. Large language models are much easier right now to work with because we have all this text. We have all this research articles. We have the entire internet. For the image-based, you really need good quality image sets, which are coming up, but they're not readily available. There's a lot of bias, like a lot of the data sets that come out of universities, for example, are things that were going to be biopsied. So they're going to be things that are higher risk anyway. They're probably going to be higher chance that it was a melanoma versus just having a bunch of pictures of moles from the population. There's a lot of differences in the skin, basically different skin sets that are represented. So I think that's a big limitation to the image base, but they're coming. They're coming is the
Yeah.
short answer. For us, we're really focused around large language models and workflow because there's so much work still to be done in that. And we even with DermGPT, we only have about 30% of the docs really using it in clinic every day. So I feel like that there's still a lot more work just to win hours back. But I agree. I mean, like that's another really big, exciting world in the dermatology is those image-based
Yeah.
algorithms that come out.
Well, and I think, what things look like now versus what it'll look like 5 to 10 years from now are obviously quite different. But I think you're smart to spend your time and energy with the team on the things that you can identify and control and help people with time. And we talk a lot in this podcast about helping folks focus on higher value tasks, or for the licensed folks operate at the top of their license, right? Like, let's give that time back, to your point, so they can do more skin checks and be face to face with patients instead of face to screen, and kind of
Right.
working in the EHR and doing all of that. So it makes a ton of sense. Well, Farah, this was a great conversation. Appreciate you taking the time to talk about your story and what you've been doing. I think it gives us all a lot of confidence as we go and see our dermatologist, hopefully for an annual skin check, as I'm sure you'd recommend for people. Just, kind of keeping an eye on their skin, making sure you're getting checked. Early identification of whatever might be happening is probably better than waiting and delaying these things. So thank you so much for sharing your story today.
Absolutely. Thank you so much for having me. And yes, 100%. Everybody get in to do the skin checks. We find things all the time. So valuable thing to do.
Absolutely. Super. Well, for folks listening, we'll include links in the show notes so you can learn more about DermGPT and check out the website. Thanks again for coming on the Health Tech Edge, Farah. And thanks to everyone for listening. If you found this useful, we'd encourage you to follow the show wherever you get your podcasts, and we will see you next time.